everybody, and welcome to the Micro e-learning program from the Global Parkinson's Genetics Program and the Aligning Science Across Parkinson's. My name is Elias Fernandez, and I am a movement disorders specialist at the University of Concepción in Chile. Today I will talk about neuroimaging for Parkinson's disease diagnosis. Today I will start with a brief introduction to PD, discuss the role of neuroimaging in PD, and review some details on structural and molecular imaging in Parkinson's disease. Parkinson's disease is a neurodegenerative disorder characterized by the accumulation of alpha-synuclein and the loss of dopaminergic neurons in the substantia nigra. PD affects about 1% of population over the age of 60. The diagnosis is based on clinical criteria, but its accuracy can be suboptimal in some cases. Therefore, there is a need for biomarkers which can include clinical, imaging, pathological, biochemical, and genetic markers. A recently proposed biologically based classification for PD called Synergy includes neuroimaging procedures as markers of neurodegeneration. In addition to the evaluation of pathological alpha-synuclein in tissues or CSF, and the documentation of pathogenic variants that causes or strongly predispose to PD. Today, we will focus on neuroimaging. Neuroimaging has several roles in PD. Most importantly, MRI can be used to rule out secondary causes of Parkinsonism and other differential diagnoses. Furthermore, some atypical forms of Parkinsonism have specific imaging features. Thus, imaging can improve diagnostic accuracy. Finally, it has been used to evaluate disease progression and the potential therapeutic effects of new compounds in modifying the course of the disease. Neuroimaging techniques include structural and molecular imaging. MRI is the most useful structural imaging technique in PD. Structural changes on conventional MRI are usually minimal and not always obvious, particularly in the early stages. Examples of possible structural changes include atrophy in the basal ganglia. The main indication for MRI is to rule out secondary causes of Parkinsonian syndromes, including vascular disease, as shown in the first figure, mineral deposition, as seen in this Wilson disease case in the second figure, normal pressure hydrocephalus, third figure, and others. MRI can also be useful for identifying specific features of atypical Parkinsonism, such as midline atrophy in PSP, asymmetric dorsal frontal or parietal atrophy in CBS, GP2 hyperintensity of the pons and middle cerebellar peduncles, also referred to as the hot cross band sign, and a putaminal hyperintense rim in MSA, as seen in the figures. However, its use may be limited due to the low sensitivity of these changes, especially in the early stages of the disease. Advanced MRI techniques can provide more detailed images of changes in the substantia nigra. Using high-field MRI 3 Tesla or more, and optimized sequences, the nigrosome 1, a dopaminergic neuron-rich region in the substantia nigra, can be seen as a hyperintense ovoid area, also called the dorsal nigral hyperintensity sign. Some studies suggest that this sign might not be present in individuals with PD, but can be seen in healthy controls as shown in the image. However, its use is limited by the lack of standardized protocols and the relatively low sensitivity compared to molecular imaging, which leads us to our next topic. Molecular imaging techniques are helpful tools for assessing dopaminergic activity in vivo. Although they cannot measure dopamine levels directly, these techniques use a marker for the dopamine transport DAT, located on the surface of presynaptic neurons, which can be used to assess the nigrostriatal dopaminergic system. From a clinical perspective, molecular imaging techniques are mainly used to differentiate degenerative Parkinsonism, such as PD, from non-degenerative conditions, such as drug-induced Parkinsonism. The two main molecular imaging techniques are proton emission tomography, PET, and single photon emission compute tomography, SPECT. As mentioned previously, the new biological classification of PD includes neuroimaging, specifically both of these techniques, as biomarkers for underlying neurodegeneration. PET imaging can be used to quantify the loss of dopaminergic neurons. The starter presynaptic dopaminergic system can be assessed using different radiotracers, such as 18F-DOPA and 11C-DTBZ, among others. The typical finding in PD patients is a depletion of dopaminergic activity, as shown in this picture. PET imaging can also help measure metabolic changes in the brain, providing insights into disease progression and potential therapeutic effects. SPECT imaging evaluates neurostriatal integrity by measuring the density of dopamine transports at the presynaptic neurostriatal terminals, which mediate the reuptake of dopamine from the synaptic cleft. The most commonly used SPECT-based imaging technique in the context of PD is the DAT scan. The most widely used radioligands are 1,2,3-iodo FP-CIT, used for DAT scans, and technetium-19M. The image here shows a diminished DAT activity in a PD patient. In summary, neuroimaging techniques are valuable tools in the diagnosis and management of PD and other Parkinsonian syndromes. Neuroimaging can help rule out secondary causes and facilitate an early and accurate diagnosis, which can be significantly beneficial for patient outcomes. Neuroimaging is also a tool for detecting neurodegeneration, a hallmark of PD, and serves as a useful biomarker. Ongoing research and technological advancements hold the promise of an even greater impact in the future. Thank you for your attention, and I hope you enjoyed the module.